And what does that mean, hemodynamics? Your heart is functioned based upon all these numbers. If you have one number short, you will not be able to function. That's what it is. And, you know, it's just like EKG. When you learn about hemodynamics, please always follow your steps. Do not skip your steps, because that's when you're going to kill your patient. You know, the same thing as EKG. If you skip those steps, 5 steps, you're going to interpret it wrong. So you have to go from step 1 to step 2. I know sometimes it could be ridiculous that you look at it, you would know, but you know, you got to train yourself to always follow your steps. So here's the hemodynamics. Like I said, it's very important that you understand the cardiac output, right? Cardiac output is equal to, remember back in your pacifist, what is it equal to?
Heart rate times stroke volume.
Heart rate times stroke volume. That's what the cardiac output is. In real life, we don't just look at a cardiac output, but we look at a cardiac index. The reason that we look at a cardiac index because every one of us have different body size. And the body size is affected by our index, right? Remember, the normal cardiac output, we say, what's the normal cardiac output? Usually 4 to 6 liters per minute, right? Your heart has to pump that much of blood every minute in order for you to function. The minute that your heart not function that much, you're going to have a little loopy or little something wrong with you. So that's what the hemodynamics. However, the index is based upon body size. For example, Byron probably needs a lot more output than I do because I'm shorter, I'm smaller. It doesn't take my heart work that hard to pump up to my head, you know, where compared to a Byron. So that's why they look at the index, right? On normal index, with usually anything greater than 3 liters per minute. And usually it's based upon the body size, right? So usually but however, remember when you're in the hospital, these patients are very, very sick, right? So we don't expect them to get up to 3.0 liter, but we expect them anything greater than 2.5 liters per minute in order for them to function. Again, do we have anybody less than that? Of course, you know, those patients have heart failure for years, try to compensate. Sometimes they can get up to 2.2 to 1.9. But, you know, these are the very sick people, right? So the ideal number in our real world would be 2.5, anything greater than 2.5. Why is it so important for you to understand this? Because we do anticipate one day you will take care of open heart patient. And, you know, what are the things that you should be doing when you take care of open heart patient or patient with heart failure patient? What are you supposed to do? So in order for them to monitor the heart function, of course, they need a swans. And you all probably say, what's a swans? The swans is a catheter that is inserted from your jugular down to your, always the tip is sitting at the pulmonary artery. And then from there they measure the fluid of each of your chambers and to see the function of it, right? So on the swans, they have 3 different ports. They call proximal, they call distal, and they call pulmonary artery. And then, if you know, the proximal is what is closest to the injection site. That's what the port is, right? So the port, the closest to the injection site would be your atrium, your right atrium. And then the distal would be all the way out to your pulmonary artery, right? So it's really important that you understand that because when you, just in case in real life that you have to inject some fluids into that swans, where would you like to inject your fluids into? In the arteries or in the atrium? In the right atrium. Which one?
Probably the most distal.
You want to inject it into the right atrium. Okay? You don't want to inject anything into your lungs.
No.
No, of course.
Right? So that's why you always inject it into the proximal port because that's to your right atrium. Right? So, having said that, just want you to know that in your cardiac output, like you said, you have a stroke volume times your heart rate. And you all have this. And then what is the product of stroke volume? Definitely your preload, your afterload, and your contractility. Right? So have right there on your slide. And then your heart rate affected by sympathetic or parasympathetic system. Those are the things I really hope you understand. So the afterload, what is it based upon? It's based upon the compliance of the vessels. The afterload is based upon the pump and the fueling pressures in the ventricle. Right? That's what your afterload is. It's going on this slide. And then the preload is anything get to do with your right atrium. Because remember, your heart has this law that the more fluid you have, like we've been saying, the more stretch the muscle is, the better the pump, right? But then again, of course, they have the limit. When you pass that limit, you're going to end up that fluid go backwards. So you don't want that either. So now, you say, well, okay, what all these mean? How do we measure these things? So like I said, we talk about swans, right? So on the swans, when you inject the fluid into the atrium, they call CVP, central venous pressure, or they call right atrium pressure. That's what they call it in your book, right? In your book, your central venous pressure usually 2 to 6 millimeter mercury, right?
2 to 8.
So, huh?
2 to 8.
2 to 8, okay. They call 2 to 8. I thought it was 2 to 6. Okay, 2 to 8. Okay, so that means that, it's telling you this is how much pressure in this right atrium. That's what it says. If anything greater than 8, that means you have, your tank is too full, right? However, I also want you to understand in the real world that, these patients are really, really sick, that they've been compensated for years. So their atrium is bigger than our normal atrium, right? So their normal pressures a little bit higher than ours, usually 10 to 12. Okay? So you probably say, well, don't confuse us. Let's just give us one number. Well, one number would be 2 to 8 in your book. That's what it says. Right? So that's what's very important. That is your preload, your right atrium pressure. That's what they call right atrium pressure, or CVP, central venous pressure. Or they call it, they also measure it by pulmonary artery diastolic. Remember, diastolic is the filling pressures, right? So that's what they measure. They call PAD. And what's a normal PAD in your book then? Usually it's about the same as CVP, 2 to 8, or 10. In the normal life, they say 10 to 12, but 2 to 8, probably the same. So that would be how you measure your preload. Now, the next thing you want to look at is your afterload, right? Again, make sure that you think that you got to look at your compliance of your vessels. Is it vasoconstrict or is it vasodilate? And you say, well, which number would we go by? Usually we look at what they call systemic vasculature resistance. So they call SVR, right? The SVR, the normal SVR in your book, again, is about 900 to 1100, they call dimes per second. I don't know why, with different measurements. But that's what they do. Because, think about it, this is called SVR. That means vasculature resistance. So the higher number, what do you guys think? The smaller the vessel, the tighter the vessel, right? So it's pretty tight there. So that's why you got to make sure that you got to think, okay, if, when you are so high, your number is so high, what should you do? You got to treat something to open that vessel, right? So you got to bring that number down. But if you have number too low, then guess what happened? You're pretty vasodilate. When you're vasodilate, what happened to your heart? Pump. Yeah, because you're not pumping. If you vasodilate so much. So you don't want that to happen either. So that's why you got to make sure, okay, is my vessels are okay, right? The next thing you want to look at blood volume or viscosity. Again, we hardly look at the viscosity. What causes the viscosity go up?
Like diabetes.
Is it diabetes?
Or dehydration.
It's usually hydration. When you are so dehydrated, your blood count a lot higher, right? Dilution of the blood. Or what else? Think about COPD patient. What's wrong with them? How do they compensate for their oxygenation? They usually make more red blood cells.
Oh.
Okay? So that's what they call polycythemia. Oh, good that you guys remember that word. Remember polycythemia? If you have such a high blood count, then you know your blood are clumping together and sticking together, and it won't go through, right? So blood viscosity would be another one. So that would be your afterload. And then the third thing is how effective is that pump, right? How much volume is in it? Just think about your patient who have heart failure, what they call diastolic heart failure. Think about this. Okay? Or the patient who have cardiomegaly. Think about the chamber. Okay, here's a heart. I don't have a heart. And then muscles, right? Think about over time, especially when they have hypertension for so long. Think about you working out. What happened to that muscle?
It's bigger.
It's getting bigger and bigger. When the muscle gets bigger, what happened to the chamber itself?
It gets smaller.
Smaller and smaller, right? So that's why the feeling pressure doesn't have to be that much, right? So again, but if you have over the years that you have what they call alcoholic people, that their heart, that is not doesn't pump as hard that it's supposed to be. So they're getting lazier and lazier. What happened to the muscle?
Just
Atrophies.
They get thinner and thinner, right? The ventricle vessel get thinner and thinner. And once they get thinner, what happened to the chamber itself?
Yeah, large.
It's enlarged, right? So the chamber is get bigger, not the muscle. So when the chamber gets bigger, what do you think the volume should be?
Larger.
You have to be bigger volume in order to pump effectively, right? So those are the things that you got to think about when you think about the afterload, right? And then heart rate. That's the whole reason why you guys are looking at the rhythm today. Now, like I said, if you have dysrhythmia, you definitely won't pump effectively. If you have any sort of tachycardia, you won't pump effectively. So those are the things that you need to look when you look at a cardiac output. So let's put it together. What does that mean? So afterload, what are you looking at? If you're looking from the Swan's perspective, what do you need to know?
Pressure in the atrium.
You need to know, afterload, you need to look at your SVR, right? That's your systemic vasculature resistance. And if you don't have the SVR, how do you know your vessel is dilated or restricted? If you don't have a Swan's.
The pump.
Viscosity and
Blood pressure. Which one?
The diastolic.
Which one? That when the heart pumps, which number?
Systolic.
Right? So the SVR or the systolic. That's how you're looking at the compliance of the vessels. Right? How do you know if your heart contractility is effective or not? Which lab or which diagnostic or which that's telling you your heart is pumping effectively or not?
CVP.
Just the CVP? No.
Remember, CVP telling you what? Preload is what?
There's too much.
Stroke 5.
But this is telling you how do you pump. That's what you need to look into your echocardiogram, right? You look at your ejection fraction, right? Because that will tell you is my heart pumping or not. And what's considered as a normal ejection fraction?
45%? No, 60%.
60%. Remember, our heart usually pump out 2/3 of our blood and they reserve the other 1/3, right? So yes, anything greater than 60% you want, then that's a good ejection fraction. You know you have a good contractility, right? So that would be your afterload. And then you know how to look at your blood viscosity. How do you know, how do you look at your blood viscosity? Which lab?
Total blood count?
Red blood cell. Very good. Yeah, red blood cell is your viscosity, right? Yeah, that's what you want to look at. Okay, now the preload. How do we know that we have good, adequate feeling pressures? Huh? But which number is going to tell you that you have adequate pressures?
CVP?
Your CVP, okay? Central venous pressures, or your right atrium pressures, or your pulmonary artery diastolic. Remember, diastolic is the feeling pressures. You have all that numbers in your book. Okay? Yes, very good. That's preload. And then the next thing is heart rate. Of course, you look at your rhythm, right? So why do I care about all these things? Now you have to treat them. So let's look at from the afterload perspective. if you have vasoconstrictors, what do you need to do?
Dilate
You
them.
got to treat them with vasodilators. Okay? Let's think about what are the drugs that you can think is the vasodilators.
Nitro.
Nitro, usually that nitroglycerin is the first choice of drug that we use, right? Because that will be, I learned there's a difference between nitro and nitride. Because the nitride is more peripheral vasodilation than central. So, but remember, when you are treating the cardiac, you want to look at the systemic wise, the central one, right? So that's why you want to use the nitro first. Nitro always the first drug to use. That you treat to vasodilate, okay? What other things that you think it may cause vasoconstrictions?
What are the drugs? Or the drugs are you saying?
No. What other things that you think the patient may cause the patient to have vasoconstriction?
He's overweight.
Anxiety. Remember, especially when you taking care of patients who are post-op open heart or any type of post-op, anxiety and pain, right? When you have pain, you do have vasoconstriction. So that's what we would do. We would treat with nitro, and then we would treat with morphine or some sort of narcotic to treat that pain. So hopefully that will vasodilate. What are the things that may cause vasoconstriction as well?
Infection or inflammation.
Viscosity.
Well, again, you keep saying infection, inflammation, but the thing is, why is infection cause vasoconstrictions?
Swelling or edema.
Even the massive poison in
But I didn't think that was vasoconstriction. Isn't that vasoconstriction?
Think about it. Infection does cause
Oh, you're right,
vasoconstriction
Sydney. Yeah.
causes
at the late stage,
and
but
dilation.
why is infection cause vasoconstriction? What's the big cause of it?
Just irritation of the lining of the blood vessels, right?
Infection is not irritation of blood vessels. Infection is just systemic infection.
All the cells you fight it off.
And what you're going to lose a lot?
Oh, yeah.
Fluid loss. Yeah? Because so dehydration also
Well,
causes
that's a volume.
vasoconstriction.
I see. Gotcha.
Yeah. When your body lost so much fluids, what's your body going to say? Let's tighten up.
Let's
I
compensate for that.
don't want to lose more fluids, right? So you got vasoconstriction as
Okay.
well, right? So that's why it's so important that, you got to think, okay, so if you're looking hemodynamically, how do you know if you are low on fluids? Or you're dehydrated?
You look at the RBCs.
Well, remember, we're talking about
You
preload.
look at the.
Okay, you look at the preload, right? The preload, all I say to you is, how much do I have in the tank? Where is my fluid level? And how do I know my preload?
CVP.
My CBP, my PADs, or my RAPs, right? Atrial pressures, right? So that's what it is. Preload, always the first thing you gotta look. How is my fluids? Is my tank full or not full? Right? Now, I'm going to treat first, is my tank full? Okay, yes, the CBP was adequate and my tank is full. The next thing you want to look at is afterload. Okay, if a tank is full, then they should have a good afterload. But why am I not having a good afterload? Am I vasoconstrict? Am I blood too thick? Am I having contractility issues? That is my afterload. Right? So if you see the preload is good, the afterload is good, why is my cardiac output still bad? Now is my heart rate. Is it at the optimal rate? Right? If you are too nervous, of course, sympathetic system kicked in, you have tachycardia, right? Otherwise, you have, or parasympathetic, maybe he's too relaxed, and then they end up with bradycardia, right? Or other issues can cause dysrhythmias, like we have been saying, electrolytes. Okay, always got to think about your electrolytes. Is that pretty straightforward for your hemodynamics?
Yeah.
Okay, so always start looking at what number?
The CVP.
Always look at your CVP, the preload, right? Is my tank full? Pretty full. And what kind of fluids should we be treating with if my preload is low? Normally, what's the first line of fluids that we should be treating?
Isotonic.
Isotonic. Yeah? Usually, we always bolus patient with normal saline. Right? what type of patient that we treat with hypertonic?